Go ahead and begin the session. Hi, everybody. Welcome to our last session with our MedTalks series featuring the topic of blood and cancers. My name is Lynn Nguyen, and I'm the Young Adult Librarian at the Chinatown Branch Library. I'm here with my co-host, Dr. Irving Dang today, who is a recent med school graduate. I first want to thank all of you for being here with us today, and especially Dr. Chung for taking his time out of his day to share everything that we need to know about blood and cancers. Thank you also to our Youth Services and Library Foundation for their generous support. Before we begin, I would like to go over some housekeeping rules. Your microphones are already muted and you don't need to have your cameras turned on. Recording is in progress. If you wish to ask questions at any time during the program, you can type that into the chat box and we'll try our best to ask that question for you during Q&A. If you did submit your questions ahead of time, those questions have been forwarded to Dr. Chung and it most likely will get answered in his presentation today. We ask that you be respectful of the program today. Personal views or anything that may be offensive will cause you to be removed from our program. Please remember to complete our survey at the very end of the program if you would like to see us continue our MedTalks series in the future. All right, so I'm going to go ahead and turn it over to Dr. Irving Dang. So Dr. Dang, for everyone that's here with us today, can you please tell everybody what MedTalks is about?
Sure. Hello, everyone. MedTalks, we created this program with the goal of educating the community on a wide range of topics regarding medicine and healthcare. We also try to fight the spread of false information that's been so pervasive lately. And then also, we want to dispel any common myths, misconceptions, or stigmas that persist about medicine and healthcare. One of the issues is a lot of this false information, it can lead to a lot of dangerous and unproven treatments that could be detrimental to your health. And this program will hopefully be able to help us fight that and get you the real facts by connecting you with healthcare professionals. Okay.
Thank you. And of course, today's topic is on blood and cancers. So can you please tell us why it's such an important topic for us to share with our community today?
Sure. So as most of you know, October is Breast Cancer Awareness Month. We'd like to highlight blood and cancers today because this is a topic that many are afraid to discuss or unwilling to discuss for whatever reason. At some point in our lives, we may know someone that has been diagnosed with some form of cancer. According to cancer.gov, approximately 39.5% of men and women will be diagnosed with cancer at some point in their lifetimes. In 2020 alone, roughly 1.8 million people will be diagnosed with cancer in the United States. And of those people that are diagnosed, about 606,000 are estimated to die from cancer. Now, this is not just a problem that affects older people. Children and adolescents, that's defined as ages 0 through 19, about 16,850 will be diagnosed with cancer. And of those, about 1,700 will die from cancer. And it is estimated that national expenditures in the US to deal with this in 2018 is $150 billion. And this is just likely to rise as the condition continues to be an issue. So with that, I'd like to introduce our guest speaker today. He is Dr. Michael Chung. He is a specialist in hematology and oncology. He's the IT physician director and physician executive member at Oncology Institute of Hope and Innovation.
All right. Yeah. Thanks for the introduction, Irving. And thank you, everyone, for inviting me here and just to talk to and share with the community about this topic and what I do, and just to learn about hematology and oncology. So are we ready to get to the presentation?
Yeah, okay. Let's do it. Thank you.
So I'm going to start my PowerPoint here, and we'll talk about this, and then we'll open it for questions. Let me share this. Can everyone see this? Yep.
Yep. Looks good.
Okay. Basically today we're going to talk about blood and cancers. That's hematology and oncology. It's all kind of in a nutshell. So we're going to go kind of quick through everything. So you're going to learn a lot of stuff about this topic. Okay. So I am a hematologist oncologist. So that I work primarily in Los Angeles right now, and I work for a private practice institution. Okay. So a little bit about myself. I graduated high school in Virginia. It's a science and technology school, and I originally went to college at Cornell University, and I graduated with a degree in computer science. That was my initial plan, was to go into do something, with computing and technology. At the same time, during college, I also developed I wanted to kind of know a little bit more as I took some classes in the basic sciences like biology and chemistry. And I saw other people that were pre-med. I decided that was the direction I really wanted to go to. Okay, so I did get my degree in computer science, but I was also pre-med, and I went to medical school right afterwards at the Albert Einstein College of Medicine, that's located in the Bronx, in New York. And I graduated from there. I did my residency in internal medicine at Beth Israel Medical Center, that's also in New York. And then I went to do my fellowship and specialized in hematology oncology at USC here in sunny California. And now I have been working here for the past 7 years about. So just to give you guys kind of an overview, of how long the whole process takes, right? So college takes about 4 years. If you're quick, you might be able to do it in 3. If not so quick, it's about 4 years or longer. Afterwards, you take the MCATs, and then you matriculate to medical school. In the US, that's usually about 4 years. There are 2 types of degrees that people usually get. There's an MD or a DO. Both are kind of similar. They're both kind of similar pathways. When you get to residency, you both do the same, go to the same residency programs, right? So medical school usually is divided into 2 years of book studying and then 2 years of clinical studying, meaning going to the hospital, seeing patients, learning under other doctors, and just immersing yourself into that atmosphere. During medical school, you take a bunch of tests, including the USMLE, which is a medical licensing exam. And then after that, after medical school, you have your degree, so you're a doctor. Okay. Then at that point, though, you apply to residency, and that may be anything in internal medicine, surgery, pediatrics. There's a whole bunch of different kind of general residencies that one can apply to, and then you do your training there, and that's typically about 3 years, sometimes 2, sometimes longer. Surgical specialties go even longer, and that's kind of, you're also just in the hospital, you're employed, so you're usually earning some kind of money at this point, not that much, but some kind of money. And you learn under residents, you learn under the attending physicians, as well as senior doctors, and you basically you learn what you're going into. So if it's surgery, you do a whole bunch of surgeries. If it's going into internal medicine, you see a lot of patients in the hospital and in the clinic. Okay, and during that time, after those 3 years or so, you take your board certification. For me, that was internal medicine. And you sit down, it's a whole day exam. You sit down for that, you take that, and then you're certified in internal medicine, okay? After that, you might decide to specialize. So internal medicine branches out into other fields like hematology, oncology, gastroenterology, cardiology, endocrinology, infectious diseases. So there's a whole bunch of specialties that you can go to, and that's usually called a fellowship. Could be another 3 more years. If you're lucky, it could be longer, depending on what you specialize in. And then you take more board exams, okay? That's what you take, you sit down for another day, and you take a whole day of exams. And then you become certified in that specialty. Now, some people are even crazier, and then they go to do even more. They subspecialize. They do even more training, and that could be just basic science research for hematology oncology. It could be bone marrow transplant for surgical specialties. It could be a super specialty in surgical oncology or something similar along that. So after you add all this up, you're looking essentially at 10 years or so of your 20s and maybe going into your 30s and beyond. And then you can be an attending physician, what we call a senior physician, and no longer in training anymore, okay? Oh, and I forgot to mention that's just a photo of me. That's not me studying, that's me training in the gym, okay? So the hematology, oncology, right? So like I said before, heme derives from the Greek word meaning blood, onc, mass, or tumor, those are cancers, right? Okay, so hematology and oncology is a combined fellowship. We usually split it. It's usually, you could split those 3 years into doing both hematology, oncology, and split it and do oncology. So at the end of the day, we do take 2 board certifications for most people that go into this subspecialty. So that's one day we sit down for a board examination for hematology, and a separate day we sit down and we get certified in oncology, 2 separate exams. So like most subspecialties or specialties, we're considered a consultant specialty. So you've heard of doctors that are like primary care doctors, maybe your PCP, your primary care physician, those are general doctors. Your family medicine doctor, that's a general doctor. Gynecology tends to also be like a kind of a general field as well. So you go and see those doctors first, and then eventually if they find an abnormality, then their patient is usually referred to the specialist, right? So that would be hematologist, oncologist in this case, okay? And so a typical day for me would be seeing patients in the clinic, okay? That's considered the outpatient facility. And then I go to the hospital and I round on patients and I see patients inside the hospital, okay? Most of these patients I see have already seen another doctor before they see me. Maybe they've seen the emergency medicine doctor. Maybe they've seen their primary care doctor first. So they've had some kind of other doctor that usually sees the patient first. They've seen them first, and they found some kind of abnormality which prompted them to send the patient over to us, okay? And what we do here, and what I do as a hematologist oncologist, I try to figure out what the problem is, what the diagnosis is, and come up with a treatment, okay? So I'm going to talk about hematology, and then I'm going to talk about oncology separately, okay? So hematology is blood, right? So what does blood consist of? White blood cells, consists of cells, which consist of white blood cells, red blood cells, and maybe something that you might not have heard before are platelets, okay? Blood also consists of plasma, which are the non-cellular components of the entire, what we say is the of your entire bloodstream. Okay, so the cells, white blood cells, are important in infection and inflammation. Red blood cells, they carry oxygen and hemoglobin to our bodies, right? You might have heard about that. Okay, hemoglobin is a molecule that carries oxygen. So we get the oxygen from our lungs, and those are delivered to our cells. Okay, platelets are a tiny little thing in the blood that helps us to stop bleeding. So it's involved in coagulation. When blood coagulates, it stops bleeding. The other half of blood contains plasma that contains mostly water, contains a lot of proteins, enzymes, hormones, some other things that help in clotting called clotting factors. It contains a lot of electrolytes like sodium, potassium, magnesium, glucose. It also contains some dissolved gases like carbon dioxide and oxygen. So as a hematologist, I work primarily with the cellular component of blood, okay? Red blood cells, white blood cells, and platelets. I also deal with clotting events and blood clots. And that's called coagulation. There are a whole bunch of other doctors that might deal with the other parts of blood, including the proteins and enzymes and electrolytes of the plasma, but that's not really the hematologist field for those. Okay, so I'm going to give you, this is just an example. Okay, maybe you've gone to your primary care doctor. Maybe, I'm sure many of you have gotten a blood sample before, right? So you go in and you get a tube removed of your blood. Okay, and one of the most common blood tests that one of those tubes are measuring is something called the complete blood count. Okay, so like we just said, it's called CBC, or complete blood count, and here it includes a few things. You might have seen the results from your primary doctor. You know, if you haven't seen them, you can always request your blood results, and this is what you'll see, and then you're kind of left wondering, like, oh, what am I looking at here? What does all this mean? And then you got to go up online, try to figure it out, because there's a lot of data here, right? Well, we just talked about, you know, a few things that the hematologist deals with, and I've highlighted them for you here. There's a white blood cell. That's you see the red blood cell. You see the hemoglobin, which is that molecule in red blood cells, and you see the platelets. And then on the right side there, you see a whole bunch of essentially the normal values. Okay, and this is just a sample. It's actually a sample that from one of my patients, and it looks completely normal. There are no flags on this because they are within the normal range, or what has been determined as the normal range. So the white blood cell count is 6.3. That's within the normal range. Same thing with the platelets. Now you see a whole bunch of other values there, but that you don't. Those are a lot of things you don't necessarily have to worry about. It's not as important as probably the ones that I've highlighted. And those other things contain information about how your red blood cells look and what types of white blood cells that you have. Okay, and for this patient, everything is normal. Okay, now a hematologist is, you know, being a hematologist, it's often like being a detective. Okay, when we see a patient, they come in with some kind of symptom, and then they have some kind of abnormality. Then we have to figure out why they have that abnormality, and that's coming up with the diagnosis. And once we know the diagnosis, we can figure out how to treat the patient. So these are some examples of just you know, typically, you know, how we evaluate an abnormality and how we come up with a treatment. So let's say someone comes in with reduced exercise tolerance. Let's say we get that CBC, or that lab test on the patient, shows low red blood cells. The medical term for that, a fancy term, is called anemia. So one primary diagnosis of anemia is iron deficiency, and then we have to do a bunch of tests to figure out, you know, why they have that type of anemia, why they have that type of iron deficiency. And then once we know the diagnosis, we can come up with a treatment. The treatment for low iron, we give iron. Okay, let's say someone comes in with frequent fevers and infections. We get that CBC. What's the abnormality? Low white blood cells. Okay, that's something below that standard range. Medical term, leukopenia, means low white blood cells. Diagnosis, maybe HIV. You've heard about that. It can affect the white blood cells. It can lower your white blood cell count, increase the risk for infection. How do you treat that? You send them to an infectious disease doctor. You get antiretroviral therapy. Okay. Another symptom, easy bruising or bleeding. Let's try to guess this one. Abnormality, low platelets. The medical term, thrombocytopenia. Okay. All these words kind of sound similar, right? Low platelets. So one possible potential diagnosis, ITP, it's a complicated term, okay? Idiopathic thrombocytopenic purpura. It means the immune system is attacking the platelets, okay? How do we treat that? Maybe try to calm the immune system down, okay? Give steroids, something called immunoglobulin. Some of these medications can increase the platelet count, okay? Because if you have low platelets, you're at risk for bleeding and bruising. Another symptom, headache, blurry vision. Not very specific. A lot of people have headaches or blurry vision. But let's say we find an abnormality on the CBC, high red blood cells. The medical term for that, polycythemia. A diagnosis, maybe sleep apnea, okay? Why? Because when you're sleeping at night, maybe you're not getting enough oxygen and your body wants to compensate. It wants to get more oxygen by increasing your red blood cells, okay? How do we treat that? Well, maybe get a machine at night to help you breathe, okay? Sleep apnea, you get a CPAP machine, okay? Another symptom, and we'll get through all of this, okay? Fever and weakness. The abnormality, maybe high white blood cells, okay? The medical term, leukemia. That's a kind of a scary word, but it's when your white blood cells can be very high, okay? The diagnosis, just for example, acute myelogenous leukemia, okay? And the treatment for that, chemotherapy or possible stem cell transplant, okay? That's a whole nother topic in of itself. So leukemia, the diagnosis for that, acute myelogenous leukemia, not myeloma, sorry, should be acute myelogenous leukemia, and the treatment for that would be maybe chemotherapy. Another symptom, dizziness or chest pains, abnormality, maybe high platelets on your CBC. The medical term would be thrombocythemia, increased platelet count. A medical term or diagnosis or potential diagnosis would be called essential thrombocythemia. And the treatment for that is a little more complex. We want to reduce your platelet count. And those medications like something called hydroxyurea, try to lower your platelets. We also try to thin the blood out, give you some aspirin, right? Because if you have low platelets, your blood might be too thin, easy to bleed. Your platelets are too high, maybe easy to clot. We want to thin it out, okay? So there's hundreds and hundreds of this, and this is how we kind of typically go through this. And it's just an example of what a particular day for me is. It's just going through patients, coming up with the diagnosis, coming up with the treatment. So this is a example of a normal blood smear. Okay, so when we can take a drop of the blood, we can put it under the microscope. The pathologist can look at it, and they can see a whole bunch of red blood cells. That's those red circles around here. Okay, these are red blood cells. White blood cells are these kind of purplish blue circles, and we see that your platelets here, right? We talked about white blood cells, red blood cells, platelets. This is normal, okay? This is a patient I saw 3 weeks ago. This is abnormal, okay? We have our white blood cells. We have our platelets. That looks like that's normal. Now we have a whole bunch of white blood cells everywhere, okay? So if any of you can know what this can look at this and tell me the diagnosis, you should be a hematologist, okay? I'll tell you what it is now. So this is chronic lymphocytic leukemia, okay? Chronic lymphocytic leukemia. And there are some highlights of these white blood cells that can tell you that, okay? So I talked about hematology, and you can get cancers in the blood, but for the most part, oncology, though, deals with cancer, like solid cancers, meaning cancers that come from other parts of your body. So where can cancer come from in your body? Well, it can come from almost every single cell in your body, okay? So your body is made up of billions and billions of cells. Any one of them, pretty much almost any one of those can become, there could become a cancer, okay? Now, what does that mean? So cancer arises when you have uncontrolled cell growth. So your normal cells, they follow a blueprint, okay? They follow a DNA, their DNA. Your normal cells are born, they live, they do their job, and then they die like they're supposed to, okay? Now cancer cells, they no longer follow that blueprint. They acquire mutations in the DNA over time, which lead to uncontrolled growth. And a lot of these can become immortal, or what we think, the idea of immortality. But this is not a cell that you want, right? Cells are supposed to follow their blueprint. They're supposed to die, okay? Now, these cancer cells, they grow, they don't follow any blueprint. It's all messed up, and they keep growing. And they form, one cell can become two, they become a whole mass, and they can become a very large mass or a tumor. And then sometimes you can even see that, right? So someone who has a very large tumor on their body, you might be able to see that just by looking at them, okay? So I just want to go, just talk very quickly about some kind of, what some of the trends that we're seeing right now in the United States and worldwide regarding to cancer and where we are, okay? So this is just kind of in the United States in 2017, this is a graph telling us what the leading causes of death are from. This is from the National Vital Statistics system here. So heart disease is by far the #1 cause of death in the United States, okay? And it's been like that for a while right now. Cancer, #2, okay? So heart disease, maybe people are dying from heart attacks. Cancer, they're dying from their malignancies, the cancers. Now you can see a whole bunch of everything else is way below that, right? Accidents, renal disease, stroke, diabetes, suicide. The majority of all other deaths are way below that, okay? So heart disease, #1 killer, cancer, #2. And we see that worldwide too, okay? This is looking at the whole world here. Cardiovascular disease, the number of deaths, and this is like in 2017, so this is in 1 year, right? So it's about almost 18 million deaths worldwide from cardiovascular disease, okay? Cancers, about 10 million deaths, okay? #2, okay? And then everything else below, respiratory diseases, lower respiratory tract infections, maybe that's gonna be a little higher this year from COVID, okay? Influenza, COVID, okay? These are infections of the respiratory tract, right? Then we see everything else going down, diabetes, liver diseases, HIV, still up there. And if you go all the way down here, there's something down here, and they also list conflict, which is a little bit interesting. That's from like war. So number of people dying from war, way lower, right? 130,000, that's not good. That's definitely not good. But cardiovascular diseases and cancers way outnumber that, okay? So this is from the just some data and statistics. Cancer doctors, we like statistics. We look at this all the time. It's like baseball, okay? So these are more statistics from the American Cancer Society. So we break down the cancer into individual cancers, and what do we see? So at the top here, we have estimated new cases of cancers, and the bottom part of this this page here we see is estimated deaths, okay? So estimated new cases for males, okay, that's here. Prostate cancer, very high among males. Lung cancer, also high. Colon cancer, high, okay? These are the top three causes of deaths, of new cancer cases, in males. For females, breast cancer, okay? So not prostate cancer, so male prostate cancer, female breast cancer. Well, we also see lung cancer, colon cancer. Okay, it's top 3 for women. And similarly, estimated deaths for males, top 3: prostate, lung, and colon. Similarly, too, for women, top 3 causes of death among cancers is lung, breast, and colon as well. Okay. So I know Irving also mentioned this when we first started off. So the lifetime risk of developing cancer from any site, 40%. So that's almost a 40% chance that anyone is going to get some type of invasive cancer in their lifetime. That's quite high, right? So that's almost 1 in 2 to 3 people, right, are going to get a cancer, right? So the lifetime cause of death by cancer, about 20%. Well, you have to have cancer if someone's going to die from it. So that mortality rate is up there as well. And so we have a graph down here. This is from the surveillance and epidemiology end results. That's a SEER data statistics from cancer.gov. And just the number of estimated new cancers cases alone in 2020 is supposed to be about 1.8 million, okay? And the estimated deaths, about 600,000 in 2020. So as we see, though, we're seeing over time, though, this is a graph over time, we're actually seeing it kind of go down, right? So maybe we're doing a little bit better overall with cancer. The number of new cancer cases is going down, as well as the cancer deaths slightly going down over time. Now, it's still very high, okay? We have a lot of work to do, but there's a slight downward trend, okay? And just like national trends in the cancer death rates, a lot of cancer death rates are going down for cancers, right? So things like melanoma and lung, we're seeing we're doing better. We're treating it better. We're detecting things earlier, right? Other cancers might have a slight uptick in the cancer death rates and incidence, and that's for women, uterus; for men, oral cavity and pharynx. Some of that is due to things like obesity, okay, diabetes. We see an increasing rate of those, and maybe some things like the spread of HPVs too. So, but for the most part, we are doing better. Okay, so just some general recommendations from the American Cancer Society. So we know that prevalence of cancer is very high. The incidence of cancer is very high. Okay, so how do we go about detecting that? So we have screening recommendations. So that these are tests that the whole population or who is at average risk of cancer. So anyone in the population, these are recommendations for screening, for detecting cancer early. Okay. So for breast cancer, there's a general consensus recommendation that women starting at the age of 40 get an annual mammogram. Okay. For colorectal cancer, okay, we tell people to do some kind of test starting around age 45, maybe to look at the stool to see if there's any blood in the stool, and maybe to do a colonoscopy, and that's where they take a camera and they look inside the colon. And there's another test called the CT colonography, which is not widely used. It's like a CT scan to try to detect colon cancer. That's where they put you in a big machine and they're able to get an image of your colon from that machine without going inside the colon, okay? For cervical cancer, usually you do a pap smear starting around the age of 25. You can also do human papillomavirus testing. I know another MedTalk about 2-3 weeks ago, they talked about that. So that's also very important for women. Lung cancer, well, there's no screening test for everyone, but there are some recommendations that heavy smokers do get a CT scan or imaging scan of the chest around age 55, okay? That's kind of someone who's at risk then. That's not for the whole population. For prostate cancer, the screening recommendations are a little bit mixed for that. Around age 50, people should discuss with their physician regarding checking a blood test called the PSA to look at. It's essentially looking at a cancer antigen or a cancer protein that's made in the blood, and also, and in addition to that, perhaps getting a prostate exam. Okay, so the screening tests are really looking for, the most common cancers. Okay, now there's a whole bunch of other cancers here, which there's no screening test for. And if we submitted the whole population to a bunch of scans of the whole body, it would be it wouldn't be that useful, because you would have a whole bunch of screening tests that may pick up little things that you're not sure about, that would prompt a doctor to try to do an extensive workup for something that might not even be there. So we don't screen everyone for cancer, for other types of cancers, only the ones that I've already mentioned. Okay, otherwise everyone would be doing medical tests for the rest of their lives, and they may not even have cancer too. Okay, so that's why there's only these screening tests for only these cancers. Now, of course, if you're at higher risk for certain types of cancers, maybe you have a family history of cancer, or there's something else about you, then you have to discuss with your physician to determine if any other further workup is necessary. So the ACS also recommends, the American Cancer Society recommends, some general diet and physical activity guidelines. So for adults, you should stay active, and that means about 150 to 300 minutes a week of moderate intensity physical exercise. That means, brisk walking or riding a bike lightly. Okay, that's quite a lot. Okay, but try to do it. Or about 75 to 150 minutes per week of vigorous exercise. So that could be running, swimming. Okay, and children and teens, about 1 hour a day of moderate to vigorous exercise. We got to get that energy out of the system. That's the recommendation. Okay, and for dietary guidelines, it's the recommendations are just to include vegetables and fruits in the diet, whole grains, brown rice, limit or try to avoid red or processed meats. Some of these processed meats are like things like that, where meats have preservatives, or they're smoked, and the way that how they cook, because they may contain carcinogens. Okay, so try to limit that. Also limit sugared beverages. That's mainly for the risk of diabetes. Processed foods, refined grains. Those are grains that have had their husks removed, because that reduces the fiber that you get in the diet. Okay. Also, the recommendations include to limit or avoid alcohol. So the number of drinks that you have per day, try to limit that. Of course, you want to try to avoid smoking, and try to limit outdoor sun exposure. That can increase the risk of skin cancers. Okay. So how do we diagnose cancer? So sometimes someone will come in with something very non-specific symptoms, right? So it could be anything. It could be some unintentional weight loss. You didn't change your diet and suddenly it's time to lose weight. It could involve decreased appetite, reduced exercise capacity. Some people have some night sweats or low-grade fevers, or it could just be worsening pain somewhere or swelling in the body. But there are about hundreds and hundreds of symptoms that you wouldn't really be able to pin down necessarily. So it's very not specific. It doesn't mean that if you have any one of these, you have cancer. It's just any of these could suggest the possibility of that. So in those cases, you should go discuss with your general doctor, your primary care physician. Okay, if you have severe symptoms, like something's just not right, go to the hospital. Right, that's when people can't handle what's going on at home. And then let's say you can't get in to see the doctor, maybe you have to go to the hospital, right? So, the doctor, your primary doctor or the hospital may do a bunch of things, including physical exam tests, blood tests, which may lead to some kind of imaging studies. We talked about CT scan, so that's imaging the body, and that might find an abnormality. Okay, so if you have a lung cancer, you get a CT scan, it might show a lung mass or a lung tumor. If you have a breast cancer, you get a mammogram, it might show like a breast mass, right? So there's a bunch of imaging tests that kind of tell us where a tumor might be located, okay? There are some other things that we can do that, that also look inside the body, things like endoscopies, colonoscopies, hysteroscopy, cystoscopy. These are all different scopes to look inside the body. So look inside the mouth, look inside the colon. Hysteroscopy is looking inside the uterus. Cystoscopy is looking inside the bladder. Okay, so that's direct visualization to try to find a tumor using your eyes through a camera and looking inside the body. Okay, so once we find something abnormal, once we find a mass, once we find a tumor, we want to do what's called a biopsy. Okay. So we want to know, what is it, okay? We want to know, what is that mass? A biopsy consists of placing a needle inside the tumor and getting a portion or piece of that tumor. Now, once we get a small little portion or piece of that tumor, we send that to a specialist called like a pathologist, and we look at that under the microscope, just like we look at a blood smear under the microscope, okay? And the pathologist can determine, is that a cancer? Is that a malignancy? They can look at those cells under the microscope and determine, is that a cancer? Because there are features that they can see under the microscope. And then they'll call it a cancer. So usually a biopsy is needed, okay? And at that point, the patient is referred to the oncologist, and then we kind of, we do further workup. We take all that information, we take all the scans, we take all those, the camera information, we take the blood test results, we take the biopsy results, and we determine where this cancer came from, and we determine what stage it is, right? So staging a cancer, there's 0 to 4 stages, okay? Most people haven't heard about the 0 stage. Most people have heard of stage 1 through 4, okay? So a stage 0 cancer, and this is just telling us, cancer staging is just telling us where the cancer is, okay? And by telling us where it is, it can help guide our treatment. It can help determine how long someone lives with treatment, and it can determine how aggressive the cancer is. So stage 0 cancer would be the best scenario for most things. That means it's a small mass, it's a small tumor, and it hasn't really grown in, it hasn't tried to infiltrate the body. Okay, that's a stage 0 cancer. Usually you can do surgery, you can cut it out, it's gone. Okay, stage 1 cancer shows that it likes to invade inside your normal tissue, inside the normal body a little bit, okay? And that's a stage 1 cancer. So it's still very low. Maybe do surgery, maybe that's it, maybe you get it out. Stage 2 cancer may mean that the cancer is kind of big, okay? Maybe it's spread to a lymph node nearby, okay? A lymph node is kind of a draining station for a lot of our body, and a lot of cancers can spread to lymph nodes first. So that might be a little cancer. The cancer might spread to the lymph nodes or little spots around the cancer. So that might be a stage 2. Stage 3 usually means that it's spread to a lot of lymph nodes, okay? Maybe surgery is very difficult, maybe it can't be done. Not sure. Stage 4 is the most advanced one, and that's where a cancer has jumped from one part of the body to another part of the body, okay? And that's usually the most serious type of stage. So sometimes the oncologist does have to break the news down to the patient, right? So who tells the patient that they have cancer? Well, maybe the primary doctor does it, maybe another doctor does it, but for the most part, most of the time it's the oncologist telling the patient that they have the cancer. And it's not always easy to break the news, okay? There are a lot of different approaches to this. There's no one right approach. There's no correct approach to this. And you really have to tailor it to individualize it to the patient. You have to deal with the family, which often come with the patient to their appointments. And so you have to customize that approach. You kind of have to talk to them and figure out how you're going to deliver the news. For the most part, though, I find it, for me, I find it very helpful to be direct, meaning, we have your bias. Let's say someone comes in, how I deliver the news, I say something similar along the lines of, you have a mass, you had the biopsy of this mass, and the results of the biopsy show that you have cancer. Okay, and that would be a direct way of saying that. Okay, you want to be informative. You want to tell the patient all the information, all the results of all the medical tests that have been done, and you want to be emphatic too. Okay, sympathize, and that can take some people just have a knack for that. Other people can take a little while to learn that. It's called empathy. Everyone in the medical field should have it because you're dealing with disease. Every doctor is dealing with disease all the time, and every doctor should empathize with the patient. Okay, so it's important to be respectful. Okay. A lot of people have preconceptions of cancer. There's a lot of cultural differences, so it's important to be respectful to everyone. Okay, and you often have to. You can't just deliver like the news and keep going and keep talking. Sometimes you have to allow the patient time to think, time to reflect on what's going on, and that's the use of silence, essentially, okay? Because nobody can absorb a lot of information all at once. You have to let it sink in. And then after that, you answer all the questions. One of the most frequent questions that oncologists will get is, how much time do I have? Well, not everyone asks that question, and it's a difficult question to answer because so it's easy to provide a number. It's say if you have stage 2 colon cancer with treatment, stage 4 colon cancer, you get treatment, you can get 2 to 3 years of life. Now, if someone asks that, then that might be the answer that I give. But I also say things, I give a caveat, right? So it's important to not always focus on the numbers, okay? The idea is that you focus on trying to make the cancer smaller. You try to focus on feeling pain-free and enjoying the time that you have as well, okay? Or at least living life and figuring out how to enjoy or how to live life with cancer. So the oncologist is not the only one who's responsible for the care of the patient, right? So a multidisciplinary team is often involved. So it's not just me, it's not just the medical oncologist. We have the surgeons, we have the surgical oncologists. Sometimes we have a radiation oncologist who give radiotherapy. That's concentrations of photons and to deliver it to the tumor, okay? There's also nuclear medicine. That's a special type of medication or drug that can be delivered that's a nuclear isotope. Okay, the team may also involve an interventional radiologist who can give treatment directly to the tumor. So liver cancer, you might be able to give radio frequency ablation. It's like strong, like radio waves to the tumor, or give chemotherapy directly to the tumor. Okay, so that'd be an interventional radiologist. Sometimes the care team also involves palliative care or pain management, and that's to help cancer pain. And then, of course, there's a medical oncologist, and we deliver things like chemotherapy or anti-neoplastic therapy, and we'll get to that in a second here. So really, the next step once you have a diagnosis is to determine the next course of action. That depends on where the cancer is, depends on the features of the cancer, depends on the stage of the cancer, depends on how the patient is doing. We call that the patient performance. It means how active they are, how functional they are. And you also have to keep in mind other things, other comorbidities or other diseases a patient may have, like diabetes, hypertension, or if they're elderly. Okay, and you have to formulate, you have to figure out what is your objective, what is your intended outcome, and you also have to ask the patient sometimes what they prefer. Okay, so there's patient input into the treatment. So just to give a quick overview of oncology, oncology is rapidly evolving. Okay, every single week, I'm not kidding you, every week something new is being developed, or a new medication is being developed. A new medication is getting approved. An existing medication has getting approved for a different type of cancer, or maybe some kind of new, like new drug or a combination of old drugs that gets approved. So you have to keep. It's almost like an oncologist has to keep up to date. I would say almost more so than maybe any other field of medicine, because things are changing every week. What's the standard of care 1 month ago could rapidly change the next month. It wasn't always the case. Okay, you go back into the 1940s. I wasn't alive then. Okay, but 1940s is when chemotherapy was first developed. The first chemotherapy was developed. Actually, they found that from chemical warfare. They found that from mustard gas. So mustard gas is chemical warfare, and it damages the cells. And they found that it also affected the immune system. Okay, and the immune system took a hit with mustard gas. So people thought that maybe they could use this to treat cancers of the immune system, things like leukemia, lymphoma. And guess what? It actually worked. It actually treated people with lymphoma. It can reduce the lymphoma by killing off the immune system. Okay, so chemotherapy has evolved since the 1940s. A lot of the chemotherapy is from plants, it's from bacteria, it's from antibiotics. Chemotherapy, though, is very not specific, meaning that it goes to a lot of your cells in the body. You've heard about some of these side effects like nausea, vomiting. Sometimes it happens, sometimes it doesn't. Okay, different people deal with chemotherapy very differently. You can't always predict it. You can get hair loss with it. You can get body aches. So there's a lot of side effects you can get from it, but not everybody will get it. However, chemotherapy, it was first developed, years ago, but in the past 10 or 20 years, there's been no new chemotherapy. Okay, actually in the past 10 years, people are not really developing chemotherapy anymore. Okay, they're moving on to different classes of medication. So it used to be the standard of care. I mean, it still is a standard of care for many cancers. It's still the backbone of treatment, but we're moving beyond that right now. So things like targeted therapy was developed, 20, 30 years ago, and that's looking at the drugs that block certain mechanisms inside the cell, certain pathways that just target that pathway and doesn't affect anything else in the body. Also develop antibodies, synthesize antibodies versus, cancer cells, okay? We've developed immunotherapy, which is, we've had immunotherapy for a while, but more recently we've developed a lot of different drugs for that. And there's more drugs being developed every week for that. And some examples of that is things that we call checkpoint inhibitors, immune checkpoint inhibitors, CAR T therapy, cancer vaccines, all these things, all these treatments, they help the immune system clear the cancer cells. Why? Because cancer cells are from our own body, right? They originated from our own body, and our immune system does play a role in cancer. So if our immune system can now recognize those cancer cells as being different from our normal cells, your immune system can take care of the cancer. So that it's a huge topic, a huge field of development right now. There's also other therapies like hormonal therapy. We can block estrogen, we can block testosterone for things like breast cancer and prostate cancer. If we block hormones for these types of cancers, we're cutting off their food supply. Breast cancer, a lot of breast cancer, they feed off of estrogen, which is the hormone in women. Prostate cancer feeds off testosterone, which is the hormone in men. If we block these, we can treat the cancer. And another treatment is also, you might have heard about bone marrow transplant, and that's very complicated. It's an entire field in itself, and that's where we take someone else's immune system and stem cells, and we transplant it into the patient. Okay, and then now once we've had all of these treatments, you can combine a lot of these treatments, right? So it's like infinite combinations that you can have with these treatments, and that's also what's being researched right now. Okay, so it's important, the battle of fighting cancer. When we start the battle, it's important to set some goals of care. Sometimes the goal of care is to shrink the cancer. Sometimes it's to cure the cancer completely. Sometimes it's just to prolong life, okay? And, you always have to keep the patient and the family, informed and in the loop, okay? And for me, it's really about being optimistic, but being realistic at the same time, okay? So the course is sometimes very long, and the treatment is certainly not easy, okay? So some people, they get a cure from cancer. Some people go into remission. That means looks like the cancer is gone. It doesn't look like it's going to come back, but we call that remission. And then unfortunately, sometimes you get a recurrence of the cancer. The cancer has come back, okay? And sometimes that cancer is very difficult to deal with, and the cancer can progress. We call that progression. So it's important through all this that just to kind of, keep in mind that man is, and women, we're all mortal, okay? And we're all trying to we're trying to fight the cancer, but at some point, and for many patients, right, like 20%, many people will get cancers and many people will die from cancers. There's always a reality to accept. And sometimes you've reached that point of an end of life discussion, and sometimes that's the point where the cancer is too advanced, it can't be treated anymore, or the patient has become too sick to get treatment. And so we involve a service called hospice, and that's a service that helps to deal with end of life care. Well, sometimes someone doesn't want any treatment, or the treatment doesn't work anymore, so they go on a service they can get this service called hospice, and that's essentially dealing with the patient, dealing with the family, dealing with pain, and to kind of face the situation of when the time comes. Okay, and many of the patients who can no longer get treatment, sometimes these are elderly or frail or people who are not very functional anymore, and these are most of the people that where hospice can always be considered. So sometimes less is more. Sometimes in that situation, not getting treatment, sometimes doing less treatment will offer more benefit to the patient, improving the quality of life rather than the quantity of life. Okay, and ultimately sometimes you have no time to prepare at all, and I've seen that. Sometimes you'll see it in the hospital. There's just no time to prepare. It can happen, a rapid decline. So with that being said, I didn't want to leave it on such a note, but the sun, sometimes this is the beach in Los Angeles, and sometimes you see the sun setting, but sometimes it's you see the sun rise, you see the sun set, but it's something that you have to take in each day, and you have to live each day, no matter what's going on. So I'd like to open it up to Irving and Lynn now if there are any questions on that. I know that was a lot. That was a lot of information.
Well, thank you, Dr. Chung. I think you did an amazing job with the presentation. We did have some questions here. Someone wanted to know, what is your relationship with patients and their families like? As someone that wants to have longer relationships and more communications with their future patients, what are some good specialties to have these kind of relationships?
Right. So any kind of, really, if you're having a relationship with a patient, you're seeing them very often, right? Because if you're not seeing them that often, then then how can you develop that relationship? So the patient, if an oncologist will have probably the closest relationship with a patient than any other doctor, right? So because you're seeing the patient, I see patients every 3 or 4 weeks for those who are on treatment, or for those who have a lot of illness and disease. I'm seeing them at least every 3 weeks. And then sometimes they get sick, they go to the hospital. I see them every day while they're in the hospital. I go to the hospital, I try to see them there. So the oncologist will have a very close relationship with the patient. Now, as you can imagine, maybe some other, specialties, maybe other chronic diseases that people are treating, like pulmonary hypertension, or certain infectious diseases, that you have chronically. You might be able to develop that relationship, but it's really, I feel like the oncologist probably has the closest relationship, because you're not only dealing with the patient, you're dealing with the family a lot of the time.
Right. Okay. So Dr. Chung, let me ask you a follow-up question. Because you have to deal with all these factors, do you believe that hematology oncology is more challenging for the mental health of the physician?
I think that it's in terms of, you can't always get a desired outcome, right? So I think that's where that's leading to. You are seeing people that die, and sometimes it's a very quiet, but sometimes it can be a lot of there can be a lot of problems too, where you have to deal with, for instance, death in someone who's very young. So I think the hardest part about it for me is really, is some of the young people that are getting cancers, and some of them that are dying from that too. I've had patients in their 20s that have metastatic colon cancers, lymphomas, and they are resistant to treatment, and they have a fiance, maybe they have young kids, and they have their parents with them in their room, they have their siblings in the room, they have their grandparents there. It's like, and some of it, can be challenging. But I did, as an oncologist, like we didn't go into this field without challenge. We know that this field is challenging. We know we're going to deal with this, and that's why we do it. We do it for the challenge.
Thank you for that, Dr. Chung. Lynn, were there any other questions that you saw?
Yeah, we definitely received a lot of questions. I guess I'll start with this one. How did you know that? How did you know that? What was the most important learning points in your medical school career, and how did you overcome difficulty?
Sorry, what was the?
Sorry.
The most, yeah.
The question was, what were the most important learning points in medical school, and how did you overcome difficulty?
Yeah. I think the most challenging learning point in medical school is when you do that, when you transition to your clinical years, I think. Because up till then, your whole entire life has been studying and has been reading books, taking tests, and a lot of what you learn in high school and college, it's a lot of it's book learning. Some of it you do labs, and some of it's hands-on, but for the most part, it's like multiple choice most of the time, right? But when you go to the clinics, when you start to see patients on your third and fourth years, you're dealing with an actual situation. You're dealing with life and death in front of you. You're dealing with patients that have that feel sick, they have pain. You're dealing with patients that that have complaints, and you're dealing with families, you're dealing with other doctors, you're dealing with attendings, you're dealing with residents. So you're dealing with a whole lot of things that you don't get exposed to just by reading books. So it's that transition between the second and third year when you go into your clinical rotations is probably the most challenging for a lot of people. Now, some people they might be a natural at it. But for me, I graduated with a degree in computer science. So I sat in front of a computer, most of my life up till that point. So so for me, it's a life learning kind of thing. So but that's certainly a challenge for some people.
So Dr. Chung, I had a question from an audience member here. When does euthanasia become an option, and how do you present it to the patient and the family?
So, euthanasia is not legal in certain states, and I think it's kind of it's a topic that, for instance, like as an oncologist, I've had some people ask me that question, but I myself don't deal with that, and most physicians are probably not comfortable in giving euthanasia, right? So that's essentially, you're taking, you're essentially making the decision to kind of terminate life at a certain point because, that patient doesn't want to deal with, it's a lot of factors. It's a very complex question. Right. Not only do they have to have some kind of incurable malignancy, but they have to have some kind of severe morbidity from that, and that's very difficult to discuss. So the number of times that I've had it, in general, if it gets to a certain point like that, we refer a patient to that service called hospice, where they can deal with end-of-life care and pain. But euthanasia, again, is only legal in certain states, and many physicians are at this point are probably not going to give that option, or at least many physicians don't specialize if they don't do that. Could that change in the future? Is that it's kind of like a moral topic at this point. So
right.
So that's a very difficult position. But I usually say this, like I don't deal with euthanasia usually, but if it's to that point where someone is accepting, death as the only outcome, I do refer that patient to hospice services, and where a palliative care team can go to the patient and go to the home. And usually patients, when they die with their family, they die with dignity, and they die pain-free.
Mm-hmm. And also, it's definitely a complex issue for a lot of physicians because it cuts to the core of one of our oaths to do no harm to the patient. And that's definitely something a lot of physicians are grappling with. But thank you for that answer, Dr. Chung. Let's see here. Dr. Chung, how did you decide to pursue hematology oncology? When did you make that decision?
That was probably sometime in my end of medical school career, because again, when you're going through your clinical rotations, or when a medical student goes through clinical rotations, they will rotate through various specialties and subspecialties, right? So soon off the bat, I knew, sometimes it's some things that you go through, you kind of gravitate towards. So oncology, I like that aspect. There's a detective aspect of hematology oncology. There's so much new treatment that's being approved, and so much research going into it, and I like that aspect of it. It was very interesting. So intellectually, it was very interesting for me. At the same time, when I rotated through my other clinical rotation, I decided, well, also, what do I not like, right? So it's not just like, what do I not want to go into? So I went through OBGYN. I said, no, I don't want to do that. I went through surgery. I don't want to do that, So for me, it was about, what I kind of gravitated towards and what I didn't like.
I can definitely understand that. I already had that idea in my mind as I was going through my medical clerkships. All right, Dr. Chung, can we discuss? So you went into some detail about some of the early stages of cancer in people. Now, what about when someone has been treated for cancer? Are there any unique signs or symptoms of cancer recurring as opposed to when cancer first happens in someone?
So it's different for everyone. There's nothing unique about a cancer or tumor or recurrence. It can happen anywhere, because a recurrence can happen anywhere in the body. So most of the time, if a cancer comes back, well, it might locally recur. It might grow back in the area where the cancer was originally, right? So you might feel another lump in that same area where maybe that lump was removed, right? Maybe some pain, and then pain that gets worse, or pain somewhere else in another part of the body. So there's nothing specific. I mean, yeah, if you go out and you play basketball, you get pain in the back. That doesn't mean that's a problem. That's a cancer coming there, right? So there's nothing really specific. You have to go with all your symptoms, and you have to discuss that with the physician to determine what else is needed. Now, normally in oncology, we follow a patient, even if the cancer looks like it's gone away, we usually follow a patient up to the average is about 5 years. So a patient will keep coming back and seeing us. So, in the first 2 years after a cancer has been treated or removed, they'll come and see us maybe every month, then maybe every 2 months. And then after a few years, they'll see us every 3 months. And then, and then eventually at year 5, if the cancer hasn't come back yet, then we think, well, maybe it's never coming back, but you don't know for certain. Okay, so most likely after 5 years, for most cancers, you might be in a remission. Now, we do scans of the body sometimes to determine, just as those CT scans, we scan the body and we look for it, but not all the time will a scan pick up a cancer. So
it's really scary. I have a question here from an audience member. How costly is it to treat cancer? And if you don't have Medicare or some type of medical, service or benefits, how do they go about getting that? And also, is hospice something that can be provided for free?
Right. So that's very complex. So in the United States, we don't have socialized medicine, right? So everyone is under some insurance, or they have no insurance, right? So you don't want to be without insurance in the U.S. Right? You don't. Trust me. I've had a patient, a 20-year-old guy, and he came in and he had decided that he felt like he didn't want when you're 20, you feel like you're invincible and it's okay. He didn't have, he decided it wasn't that he couldn't afford insurance, decided that maybe he didn't need it. So he went into the hospital, he had fever, he had what he thought was a respiratory illness, and that he had leukemia, right? He had to have a bone marrow transplant eventually. Okay, so he was able to get insurance, but so there's the cost of care in the United States are very high. It's just not affordable, even for someone who is well off. You cannot afford it without insurance, like cancer care. Now, maybe for certain cancers that don't require much treatment, maybe you could pay out of pocket. But that's the whole reason why a lot of people are going to other countries sometimes and getting their care over there, because the out-of-pocket costs are less. So there's definitely something in the U.S. that kind of needs to, cancer care needs to be made more affordable, and everyone needs some kind of coverage. Now, whether that be in the form of insurance for everyone, or subsidized insurances, or but everybody needs to be able to get some kind of care, because if someone does not have insurance, it's astronomical what the cost of cancer care could be.
Absolutely. So right now we're at 5:18. We're gonna wrap this up by 5:30. Let's tackle a few more questions. Let's tackle some myths specifically, Dr. Chung. Would you mind talking to us about this is a question someone submitted. How dangerous is it to stand next to a microwave? Can that lead to cancer? And also, is it safe to sleep next to my cell phone? Because I've heard a lot about the cell signal possibly leading to cancer. Could you please shed some light on that?
Well, there's really a lot of conflicting data, right? So we do know that if you're near certain kinds of like energy waves, we know, for instance, if you're outside in the sun, it's high exposure to UV radiation, so can cause skin cancer. So certain types of radiation can cause it, right? We know that if you live by a nuclear power plant and like Chernobyl, and then they had experienced a meltdown, yes, those are high doses of radiation. You can get cancer. If you're up in the stratosphere, up in the, like if you're up in the, in space, all the time, you can be bombarded with, you're getting radiation all the time up there. So we know that certain levels of radiation can do that. Now, like things like cell phones and microwave, those have not really been proven, and sufficient amounts of energy to really cause it. Now, I know there is some conflicting data on that, right? But everyone, they say, okay, well, they can look at that. They look at, so if you have, is it linked? So some people think, okay, maybe if you're closer to it, then you might get cancer. But we're not seeing that case all the time. So that's just a general thought that being close to high amounts of radiation cause cancer, but those have not been necessarily proven in low amounts like that.
Okay, thank you for that. And then we also had a question here. There seems to be some confusion out there from the public. How is the self breast examination still recommended?
Yeah, so I think usually I think a woman should be able to examine their own breast and be able to determine what feels normal to them and what is not. Now, should that be used alone? No. I think a physician should also do a breast examination. Again, the screening tests are at age 40, right? Annual mammography and breast examinations to be done by a clinician.
Mhm.
But a woman should also actually, learn a little bit about how their breasts kind of feel and they look like. And if there's something abnormal on it, they should let the physician know. I've had patients where sometimes the screening mammogram didn't show anything,
Right,
but the
right.
patient felt something there, right? The patient felt something there, and it turned out to be actually a breast cancer. So remember, not all screening tests are perfect. There's a
Right.
lot of false positives and a lot of false negatives.
Absolutely.
So, so they should. So it's important to at least kind of get a certain feel for at least to get a feel and kind of do it on your own. But it shouldn't supplant the need for the screening test.
I definitely agree. Dr. Chung, could you talk real fast on the role of autoimmune diseases and allergies in cancer?
Yeah. So it's kind of interesting because the how cancer forms, right? It's a way of it, because there are abnormalities that happen in our cells all the time, and our immune system is able to go in there and remove abnormal cells. We make abnormal cells all the time, right? So the immune system can identify the abnormal cells that we make sometimes and prevent, a cancer from a precancer from developing. So allergies and autoimmune disorders are often associated with an overactive immune system.
Mhm.
Something that where the immune system is attacking the body. Sometimes it attacks the skin, you get a rash, right? Sometimes it attacks the joints and you get joint pain, like lupus. Or sometimes it attacks the platelets and you get low platelets, right? So the immune system can be overactive in a lot of conditions, and what that can do is sometimes it can cause inflammation, right? So there are some medical disorders, some autoimmune disorders like ulcerative colitis, Crohn's disease, inflammation of the colon, and so you have chronic inflammation of the colon, right? And that's essentially it's an autoimmune disorder, but it's associated with a higher risk of cancer because when you have a lot of inflammation, it's kind of like those cells are being overactive all the time, and they're being attacked by your immune system, and then they're trying to regenerate. So imagine this, like it's like what's gonna break down faster, right? It's like if it's like a car, right? It's like a car that you use all the time. So you're out on the road all the time. Eventually, it's going to break down. Something's going to happen. A problem's going to happen with it. So it's the same thing. It's like it's being constantly in use and constantly being attacked by the immune system. So there is an association with inflammation and the pathogenesis or the development of some cancers. Not all cancers, but some cancers.
Mm-hmm. Okay. I guess, Lynn, do you have anything to?
Let's just go ahead. We'll take one question here from Natalie. What can you tell us about medical student and resident physician burnout, depression, suicide rates in recent years? Any oncology residents specific data, female or male physician suicide rates?
I'm not familiar with the most recent data on a lot of the medical students. I know that in the past, if you're talking about versus like 10 or 20 years ago, physician, we used to have no like limits on like how long you can, be on call or be awake, right? So and then I think during, when I became a resident, I would often go like 24 to 30. Sometimes I'd go 24 to 30 hours, with no sleep, right? So that can certainly take a toll, and I think that they're doing better with the regulation. I think the medical students and residents they put these up, and then there's more regulations, and so to the amount of time that a physician can actually stay awake or be on call, right? So for the oncologist, though, for me, like I don't do 24-hour calls. I'm not awake all the time. So I have almost like a 9-to-5 type of lifestyle. So it's better for an oncologist. That's why I selected this. But for other certain specialties where you have to be like there for 12 hours or 24 hours around the clock, that's very difficult to do. But it's tough. It's tough if you have to be up all the time.
Thank you. I hope that answers your question. I have another question here. I think this might be a good one to ask. For a woman who has breast implants, can they still get breast cancer?
You know that there are some relationships with certain types of implants and cancers. Now, there, for the most part, you know, for a lot of the newer materials that they're using, that's thought not to be, you know, the incidence of that is going way down. If you go way back, you know, again, we run into this putting foreign materials into the body and some of that causing inflammation in the body, right? So some of the older ones were really associated with that, but the newer ones, for a lot of them, I mean, they're thought not to really cause that for some of the newer materials. Now, again, I'm sure the plastic surgeon would probably be able to tell you more about the specific type of materials on that. But for a lot of my patients that I've seen, many of them have not gotten. Majority of my patients, even with breast implants, have not gotten cancers from their breast implants.
Okay, with that, let me ask you one last question before we wrap up. Dr. Chung, do you have any recommended reading resources to learn more about allergies and autoimmune inflammation as a potential risk for some cancers? Any recommendations for sources on prevention as well?
You know, that there's so many resources out there with the internet, and if you're looking for very general kind of sources, like most of the cancer statistics that I cited are from, like, you know, cancer.gov, epidemiologies, and they even talk about cancer risks. But in terms of autoimmune and inflammation, you probably have to start specifically. I mean, you could go through. You'd have to go through more of an immunologist kind of resource for that, because when it comes to certain types of those diseases, you know, you want to. There's probably much more data if you go directly to, like, if you have a specific autoimmune disorder, right? So you go to the resources for that specific disorder, and that might be through a rheumatologist. You know, that might be through an allergy immunologist, and there's so many resources online for that. You can, to learn about that, you can pick any of them, but a lot of them for cancer related at risk. I mean, cancer.gov is a great website for that. NCCN, the National Cancer Institutes, they also have a lot of resources as well. So the NCI, National Cancer Institute, they have a lot of resources for that too.
All right, thank you very much for that, Dr. Chung.
Yeah, thank you so much, Dr. Chung. And let's we'll go ahead and we'll conclude our program here today, because you've shared so much great information. I'm sure everybody here appreciates it. And thank you for answering all of those questions from our audience members here with us today. We hope that everybody here found this program to be useful. So please do take the time to fill out our survey. Thank you, Greg. Dr. Chung, do you have any last words for our audience members?
No, I mean, you know, thanks for the opportunity for having me here. I think it's great to kind of, you know, give some information to the public about this, and, you know, hopefully a lot of our young participants, you know, if they're thinking about a career in medicine, to kind of, you know, hopefully they've kind of learned a little bit about what a doctor does. You know, I know when I was younger, we didn't have these kinds of things. You know, you'd have to, you know, the best way to kind of learn things would be to go and shadow a doctor, which is it's a hit or miss on that.
Right.
To figure out what a doctor does, right? So I think, you know, the program to introduce, you know, to young adults about, you know, what a specialist or what a doctor does, and eventually how, you know, if people are interested in medicine, get them interested about it. So So I think this is a great program, guys. Yeah.
Thank you so much for coming on. We really appreciate all the work you put in for the presentation and taking time to answer all the audience members' questions. And then for everyone that's still here, I know this is the last MedTalks in the series, but don't worry, we are in plans on starting up MedTalks in the near future. So when that happens, we will definitely let everyone know, and we will continue MedTalks again. Anything else, Lynn?
Yeah, no, I think that's it. So Irving and I will stick around for the next 5 minutes. There's so many excited people. We'll definitely stick around for the next few minutes to answer any last minute questions. But Dr. Chung, thank you again. We will let you go.
Okay.
Okay, thank you so
Goodbye,
much,
Dr.
Dr.
Chung.
Chung. Bye.